on, he received his PhD from CBU and engineering degree from Oxford, and has worked a lot in electronic health record and open access community, and started the Open Health Informatics program, research program at CBU. So with that, I will just pass it on to John to talk about this timely topic.
Okay, thank you, Andre, and thank you for the invitation from Abdul Rizadi to come and speak today, and also tomorrow, actually. So I'm going to spend, hopefully not too long, talking about eHealth and telemedicine in Ukraine, a number of projects we have going there, and then a little bit more widely at the end about a initiative that we started at Fordham University in New York, which I very much hope will involve UVic as well, rather grandly entitled Global Open Source Health Records. So we'll see that at the end. So I'll just start by introducing an open source electronic health record system. I do this up the front because I'm going to mention this a few times as we go through. So rather than explain every time we get to it, I'll just tell you about it now. So this system, CityEHR, is a system that I started designing about 2010. And it's an example of an open source electronic health record system. It's a 100% model driven system. So you build a model using the ISO 13606 standard of electronic health records, and then you generate a full EHR system. And the record itself is stored in the HL7 CDA clinical document architecture standard. It supports various other open standards, including various coding schemes, in fact, any coding scheme. And it's deployed in a couple of hospitals in the UK, in England, one in Oxford, one in London. And we'll see at the end that it's starting to roll out in other places as well. So really came to talk about Ukraine. So just setting the scenes, there's a map of Ukraine with all its sovereign territory intact. Pictures at the bottom there are Maidan Square in the center of Kyiv, and the World Bank offices in Kyiv, both of which are a little bit relevant to what we'll talk about later. Ukraine itself is totally about 45 million people, has about 60 million rural inhabitants. And if you look at the picture of central Kyiv, in fact, both those pictures of central Kyiv, you see a cosmopolitan European city, like it's like being in Munich or Paris or London. But once you get outside of Kyiv, there's really been little investment in the infrastructure since the end of the Soviet era in the early 1990s. So once you get to the rural locations, it's almost stuck in a 50-year time warp. And partly as a result of that, life expectancy in the rural areas is very low. So overall life expectancy for men in Ukraine is about 66 years. In the rural areas for men, it's about 62 years. So way below what we'd expect in Canada, the US, or the UK. In terms of GDP per capita, then Ukraine is classified as a low-income country. So around 2015, the World Bank started a project funded just over $200 million project, or supporting the reform of healthcare in Ukraine. And there are a number of reasons lying behind this, partly because by 2015, which was the year after the Maidan Revolution, I'll come back in a second, Ukraine had started looking westwards, and particularly to joining the European Union. And it needed to bring its healthcare services into line with the sort of service you'd expect in the rest of the European Union. And also because of the way that healthcare was organized, it was one of the areas which was ripe for corruption, which was another reform which was needed generally in Ukraine as it looked to join the EU. Part of the reform was for the first time to have a national patient identifier for all citizens of Ukraine, and to have every citizen sign up to a primary care practitioner. So it's development of primary care practices and the assignment of one patient to, of each patient to one and only one GP practice, and then to instigate practices which are pretty commonplace in most developed economies, where the first point of contact was through the primary care physician with referral to hospital and other secondary services through the GP, replacing the previous free-for-all where patients did see their local general practitioners. We weren't registered with them for any condition which required hospital treatment. The patients would go directly to the hospital, and then they would pay directly the physicians in the hospital directly in cash, and that was a big source of corruption in the healthcare system. So a major reform to channel healthcare through the gatekeeper of the primary care physicians. Slightly later, but as part of the same overall initiative by the World Bank, was an initiative funded by, amongst others, the Swiss Development Corporation, Swiss Sovereign Fund, to introduce and support telemedicine systems in Ukraine, which is where myself, Abdul Rizadi from UVic, and Concha Grania from the Norwegian eHealth Research Centre got involved, as we'll see. So in 2018, Abdul and I made our first trip to Ukraine, and I just picked a few things just to give an impression of what healthcare is like in Ukraine. And as I mentioned, outside of Kyiv, this is really what most of the country is like. So in the top left-hand corner is a Feldsher station. So that's a Feldsher is a field nurse who tour around the villages and providing clinics normally once a week in the local Feldsher station. So there's a picture of a Feldsher station. We've got another picture coming up in a second on the inside. It's basically a hut in the village and pretty primitive facilities. Bottom in the centre is a district ambulatory centre, and the World Bank funded a programme to build new ambulatory centres across the country. They made blueprints of the standard architecture of the building and equipment, and funded a programme to build new ambulatory centres. That one there is not a new one, it's a fairly old one. In the centre is the regional hospital in Poltava, and on the right-hand side is the main road to Poltava. So the splodges you see on the road are potholes. I mean, this is the main road to Poltava. And you can see a lorry coming the other direction. And it's quite an interesting journey with the bus driver who's weaving across the road to avoid the potholes, which then puts you in line to head with the oncoming trucks, and then interesting decisions as whether to go into the verge on the left-hand side, avoiding truck and potholes, or hit the truck or go in a pothole back on your own side of the road. Anyway, that was an interesting journey. Continuing that sort of theme, in the bottom left-hand corner is the server at the district hospital. I've called it the server room. It's not really a server room. An office with a small cabinet in with one server and one hard drive attached to their network. The hard drive, which is the box at the bottom, is managing their PACS, patient archive and communication system for their digital imaging, and the server, which is just above it, is running the electronic health record system for the hospital. So in somebody's office in a little cabinet like that. So I show these photos to illustrate a couple of the issues with telemedicine. So on the left-hand side is inside one of those Felsher stations, and that's the medicines cabinet. So you can see that it's pretty primitive, and the whole of that Felsher station is very primitive indeed and insecure. So they regularly have people breaking in. You can see how easy it would be to come in and steal medicines from there. But similarly, if you were to install any expensive IT equipment down in the Felsher station, then that would likely go missing pretty quickly as well. There's no communications, there's no fibre cables laid to the villages and rural locations. There is fairly good mobile health coverage, mobile phone coverage, and most villages have line of sight to an antenna, which I'll come back to in a second. When we arrived in 2018, the World Bank money had already started to be spent on telemedicine. And what we found is that because the World Bank funds capital projects, so there was a need to spend on stuff, capital expenditure, rather than invest in services, then a lot of money had been spent on buying telemedicine kits like the one shown there. So generally with equipment for blood pressure, ECG, spirometer, etc., all in one kit. And those kits generally come with a connection to some sort of cloud service run by the provider of the kit. So that we come back to in a second as well. So that was the general state when we arrived 2018, very low tech or no tech infrastructure locally, and money spent generally on pieces of equipment which standalone weren't really of any use to anybody. So over the course of the next 18 months, we developed a handbook for rural telemedicine in Ukraine, and that was used to guide some pilot implementations in 3 districts, so Poltava and Odessa regions, and the Rivne region. Rivne shows some pictures of in a second. Rivne is approximately halfway between the Polish border and Kyiv, about a couple of 100 kilometers. In fact, might border Rivne city, but I think the oblast probably borders Belarus to the north. So we made a number of recommendations in this handbook. Some of them were for the good of telemedicine. Some of them were actually aimed at trying to steer the way that eHealth was going in Ukraine. So we recommended implementing telemedicine at local, district and regional level, and citing the main infrastructure for telemedicine services in data centers at the regional hospitals. So there's 42 oblasts, I think, in Ukraine. So no, that's probably wrong, 28 probably. Anyway, there are a number of oblast regions in Ukraine. And we recommended building a data center, a server room in each of those hospitals, with some infrastructure mirrored at district level as well. And part of the reason to do that, in fact, 2 main reasons. One is to try and avoid the proliferation of private, actually public cloud services. So that telemedicine equipment that was being introduced all over the place was connecting to cloud services run by the provider of the equipment. And once in there were 2 problems. One is the data was at the mercy of the provider of the equipment. It wasn't integrated with any of the rest of the eHealth infrastructure, and they had to pay for it and pay for the service. And the World Bank was funding equipment, not service. So a lot of that equipment actually remained unused because there was no funding to keep the cloud services going. So data was transferred up to cloud service for which they didn't have funding to keep going. The other reason to put data centers in the regional hospitals was because there's little to no IT infrastructure in the hospitals themselves. So building server rooms in the regional hospitals brought up the level of basic IT services in the hospitals themselves, and gave them the ability to connect. So as we saw that server room, in quotes, at the Poltava District Hospital, Poltava Regional Hospital, the ability to actually have a proper server room, a proper network infrastructure, have resilient supported systems just in the hospital, let alone for telemedicine. We also tried to address the problem down at the Felsher stations in two ways. One is to fit antenna to the Felsher station. As I say, most Felsher stations have line of sight to mobile phone base station, and you can get pretty good connectivity, either 3G or 4G, through a directed antenna, and then bring the inside the Felsher station to a router for a minimal network inside the Felsher station. In fact, same infrastructure at the ambulatory centres as well. But even with antenna and mobile phone data link, then the bandwidth was a bit restricted, to say the least. So we recommended running virtual desktop infrastructure inside the Felsher stations. So that was the minimum bandwidth to run anything. It also meant that they could run all of the telemedicine service down at the local level without any local installation or support on any machine, with actually no data ever appearing other than to be viewed in the Felsher station itself. And if the equipment got stolen, which it almost certainly will do, then you've lost maybe $100 laptop or PC and no data. So that was part of the recommendation of the infrastructure, to use a virtual desktop infrastructure. And I've mentioned the problem of the public cloud. So we suggested some architecture of a national gateway to try and integrate with the existing cloud services which were being used, and also not shown in this slide, to try and bring in a virtual private network for the health service of Ukraine, and to run cloud services within that if it was necessary indeed to run cloud services at national level, and try and bring that integration actually down to the regional level, so that in the future the devices connecting from the Felsher station through virtual desktop infrastructure could actually then connect directly to the servers running at the regional level, rather to third-party cloud services. It's a big problem, not just in Ukraine, that it's easy to get up and running with a third-party cloud service, but you start to create silos of information which is accessible only through that service and not integrated easily with the rest of the electronic health record. And added to that, in Ukraine, you need to find the funding ongoing to pay for the cloud service as well. So that was 2018 and 19. And then just as we were getting going on perhaps doing something practically, it's a bit frustrating if anybody, I'm sure a fair number of you have done consultancy gigs with the World Bank or World Health Organization. You've discovered all this stuff, and actually I'm an engineer. I really wanted to actually build some stuff rather than tell people how perhaps they could go about building stuff. So COVID got in the way, and then we started a war. So earlier this year, in March of this year, we ran, actually for the second time, a workshop on implementation of model-driven electronic health records, and we invited a delegation from Rivne in Ukraine. Actually didn't think they'd turn up, but they did. So they came over in March and started learning how to deploy open source electronic health records, in particular the City EHR. And this has now progressed to a discussion about two projects. Actually, when I get to the end, you'll see they turned into one project, but at the time progressed into two projects, one for the integration of telemedicine systems into open source infrastructure, and the other for the transfer of patient information using a standard called the European Patient Summary. And if anyone's interested in joining next year, it's 17th to 22nd of March next year, where we intend to have people again from Ukraine, but also from Nigeria, Pakistan, and probably Moldova as well. So welcome to join us there for that. So why Moldova? Well, Moldova is also a very low-income country between Romania and Ukraine, with borders to Ukraine in the north. Most of its eastern border is actually with the Russian enclave Transnistria, and in that map, but the bottom to the south is also Ukraine. So Ukraine, Odessa Oblast sort of bends round past Odessa, and there's that second part on the other side of the river, which is also Ukraine, which again has a border with Moldova. Moldova GDP per capita is slightly higher than Ukraine, but I think that's actually a bit of a whatever it is, there's something else going on in the GDP per capita, because Moldova is a very poor country. Life expectancy is also a bit higher than overall than Ukraine. So in July this year, I went with the World Health Organization to Moldova for two reasons. One is Moldova is looking to implement a national eHealth infrastructure, including electronic transfer of prescriptions and telemedicine. But also, Moldova is taking in a large number of refugees from Ukraine who are crossing the border, as is Poland's. Over 1 million refugees have settled in Poland. And the World Health Organization has various projects ongoing to try and transfer health information with those refugees across the border. I show those pictures because that's center of Chisinau, which is the capital of Moldova. There are some slightly grander buildings, but by and large, the city of Chisinau is like that. And it's a bit bizarre as well, because most cities have some suburbs, whereas Chisinau is in a bit of a bowl, and with quite a lot of high-rise apartments or medium-rise apartments, and then the city just stops, and then there's fields. There's basically no suburbs. It's slightly difficult to explain, but a slightly strange experience going there. So we had a workshop. Most of the people in that picture are Moldovan IT or clinical specialists, and we started developing there and then a model-driven electronic health record for cross-border exchange of health information using the European health summary, the European patient summary, in Ukrainian and Moldovan, which is actually Romanian. So the European patient summary are guidelines published by the EU with the intent of having a summary record which can follow citizens of Europe as they cross borders in the European countries. And it's sort of got in it, that's a list on the left-hand side of the contents of the European patient summary. And it's the sort of things which you'd expect in a summary record, sufficient to provide information should a citizen who's out of their home country require medical attention while they're abroad in one of the other EU countries. So it's published as a standard, which is in document form. It's also published as the international patient summary, almost without change. So both the European patient summary and international patient summary are more or less the same standard. So the left-hand side headings are as implemented in the City EHR. So at the end of August this year, I repaid the favour of our delegation from Rivne, and I visited them in Rivne. Getting to Ukraine is not particularly easy, although on the other hand, it's not particularly difficult. So you fly to Poland, I flew to Krakow and caught the bus overnight. Most of the buses travel overnight, so you cross the border in the middle of the night. Going there, it took about 2 hours to cross the border. Coming out, it took about 5 hours to cross the border. I arrived on a Sunday morning, and Rivne is pretty much untouched by the war, or so it seems when you arrive. So city functioning as normal. I'd visited there before. It's pretty much as I remembered it. People going about their everyday lives. We went on a tour of the city. That's when I started to notice how people are coping with the war. So Rivne itself only had 2 missile attacks, one on the power station and one on the city itself. So in 18 months of war, that's relatively untouched. People are a bit tense, as you might imagine, and part of their coping mechanism is a sense of humour. So the picture at the bottom left is a shooting range with an air gun in the local path where you can take pot shots at Putin. I apologise if some of this still verges on politics. I try to steer clear of the politics, but I'm trying to explain how a sense of humour prevails. And continues in the Children's Museum. I mean, it's quite bizarre and perhaps in bad taste, but in the Children's Museum, they have a big exhibition for children. Behind me taking this photo is a big display of all the military hardware which has been donated or given to Ukraine, which is a lot. In fact, you don't realise how much till you see a big display with pictures of everything donated and all the different countries who've contributed to helping them. On the other side, you can throw skittles and beanbags at pictures of Putin. Now, when we were there previously, the general population, particularly in Kyiv, there's a lot of Russian speakers there, and the general attitude I detected was quite relaxed towards Russia and Putin, but obviously not anymore. So when we got down to work, first thing to do was to visit the head office for the NGO 100% Life Rivne, which is where the 3 people from Rivne who'd visited Oxford, they work for this NGO. So before the war, then the NGO is largely working on projects helping HIV, AIDS, tuberculosis and other long-term conditions across Ukraine. It's the largest NGO in Ukraine. Since the war, they got involved in distribution of aid to internal refugees. So Rivne attracts quite a lot of internal refugees. And one of the things which they were very careful to point out to me is the extent they go to avoid, to prevent corruption. So all the handout of aid is carefully documented. You have to have ID to claim anything which you receive from them, and it's documented as to what you're given, and etc. That again is quite a cultural change from 2018-19 to now, and you can see that the headquarters of the 100% Life Rivne is a fairly typical Ukraine head office for such an organization. Next thing to do was to visit the regional hospital. So this is the main hospital for the Rivne Oblast, provides specialist services across the whole region and supports referrals from both primary care and from the district hospitals and ambulatory centres. So that is the hospital. It hasn't been hit by a missile or anything. That's what hospitals are like. And in fact, that's what hospitals are like in Poltava, Odessa, or the other places that we visited them. These pictures in the background there is the Regional Children's Hospital. And on the left-hand side are some murals painted with the assistance of children from the Children's Hospital, but mainly made by artist Konstantin Kachanovsky, who's dubbed the Ukrainian Banksy. So Banksy's been at work in Ukraine, but Konstantin Kachanovsky has as well. We've got a few more of his paintings coming up. I visited in that hospital, their server room. So that picture of the outside of the hospital, when you go inside the hospital, it's more or less as you'd expect from the outside. What they have been able to achieve with the World Bank money is to build a proper server room. It may not be quite what we'd expect a server room here, but it's orders of magnitude better than what they had before. So it's got a proper air conditioning, it's got fire control, it's secure, it doesn't have any holes in the roof or the walls. That's on our first visit to Odessa, they had a server room, which was a room like a broom cupboard. And when I walked in, I said, well, your air conditioning seems to be quite good. And the guy said, well, actually, it's because of that. And he pointed to a big hole in the wall, which was where the cool air was coming in from. So this is a properly constructed server room. It only has one cabinet in, but it's a proper cabinet, and they have a resilience for this, so it's properly backed up, and they have another location for this. So it's a good start on getting a proper IT infrastructure. The hospital lady on the right, Victoria, is the head of the IT services in the hospital. Underneath the hospital, they have a bunker. So it's a 800-bed hospital, and they have a bunker, I think, with room for 300 people in it. And they've spent a lot of money in the last 18 months refurbishing that. So it was a Soviet-era bunker, which has been closed since the early 90s, now refurbished with proper air supply, water, power, but only with capacity for 300 people. And it's decorated with a lot more of the Konstantin Kachanovsky paintings, which are depicting heroes of the war. The day after I visited the hospital, we took a road trip to Kyiv, which takes about 4 hours. I have to say I was a bit nervous about going to Kyiv, because it does get a missile attack virtually every day overnight. Most of the missiles are intercepted, but I think they're all virtually intercepted now. But some of them get over the suburbs before they're intercepted, and then the debris falls on the suburbs, which is most of what you see on the TV, if something, if apartment blocks being hit, etc. We went to the Ministry of Health, which is in a secure zone in the city centre, where you're not allowed to take pictures anyway. But actually, I have to tell you the truth, I forgot to take any pictures until on the way out, where I managed to take this picture. which shows life as normal. So Kyiv is exactly, in fact, if anything, it was busier than I remember it. People going around shopping, traffic jams, just normal cosmopolitan city life in Kyiv. It's almost as if there's no war going on day to day in there. So we met with the Deputy Minister of Health, did the obligatory photos, with the intention of setting up a practical project in Rivne to take on the telemedicine services, such as they've been able to get them going with the World Bank investment, and move forward with some eHealth. The gentleman second from the right works partly for the Ministry of Health and partly for the university in Kyiv, and has developed a comprehensive catalogue both of eHealth, the state of eHealth in Ukraine at the moment, and of telemedicine. Since the war started, a lot of telemedicine equipment has arrived in Ukraine, and sort of adding to the same problem that we observed with the World Bank funding of throwing in equipment which would do a point-to-point teleconsultation, and some of it from the war zones to people located in experts in other countries, is something which is obviously useful now, but it's not sustainable for the future. So part of what we're trying to do is some sustainable telemedicine services for the future. So I apologise if this is overly political, but having been to Ukraine, I think it's important just to mention a few things that are going on there. So in this is the centre of Rivne, the central square. In the background are the memorials to people from Rivne who lost their lives in the Maidan Revolution in 2014. And there are a dozen or so of those, and they've been there for almost 10 years now. If you visit Maidan Square in the centre up the hill from the square up to the government areas, then they have pictures of everyone who died in the revolution. And on the one hand, it's a bit shocking to see, but on the other hand, there aren't that many in terms of compared to this. So this is the memorials of soldiers from Rivne who have lost their lives in the war. And for these, there's, I don't know how many there are, there's hundreds in Rivne. And in fact, as the bus comes from the border, every little village and town that you pass through has memorials like this. You start to realise how what a heavy toll it's taken on the population. So that's the situation there. With people getting on with it, what can we do remotely to help them? Well, we can get on with it as well. So we're started a project now to introduce open source electronic health records into the Rivne Oblast with a number of objectives. So the World Bank funding has helped them to implement the infrastructure, if you like, for telemedicine, and they've bought equipment. They've got a real problem with the fact that when they make examinations using their telemedicine equipment, it's then uploaded to this cloud service, which is not properly integrated with the rest of their electronic health record systems. And they do have some electronic health record systems, and they can't afford to pay for the ongoing service, for the cloud service. So that needs to be sorted out. At the regional hospital itself, then they don't have any rooms equipped for teleconsultation. So we have a plan to try and get 8 rooms up and running properly with the equipment they need there, so that they can actually run clinics, both regular hospital clinics and telemedicine clinics out of those rooms. Actually, the biggest problem they have is with integration. So they are not able to integrate within the hospital, so their labs and diagnostic imaging. Neither can they properly integrate with those data which are coming from the telemedicine devices. I would say the telemedicine devices is secondary to, I mean, we would expect a acute hospital to have integrated labs and diagnostic imaging with the medical record, but they don't. And the regional authorities, who's again are supporting this project, are very keen for there to be a proper analysis and reporting of what's going on in healthcare, which is again part of the drive towards countering corruption in Ukraine. So our pilot project, which is supported by the Ministry of Health, organised at the top level by the NGO 100% Life Rievner, and is based at that hospital that we saw, the regional hospital, and a number of other organisations in Rievner, including the local technical college and the Luhansk State Medical University. So Luhansk State Medical University is now located in Rievner, which is hundreds of miles from Luhansk. So that medical university is relocated twice, once in 2014 when it was overrun by Russians, and again in 2022 when its new location was overrun by the Russians. So now it's in Rievner, which is a bit safer. So what's happening there in terms of that project is to introduce two pieces of open source software. One is an integration engine, a Mirth integration engine, in that server room, which we saw earlier, which will integrate in the hospital labs and diagnostic imaging, and also provide proper integration with the Felsher stations, the ambulatory centres and the district hospitals, so that we don't have to use the cloud services, which can't afford to pay for. That will feed into a general repository from which they can do their analysis and reporting. And once we've got that, then we can connect the City HR open source health records to the repository, just to initially to have a look at what's in there, so we can use it to view what's in the repository. Longer term, and longer term being maybe over the next year, then the intention is to try out making a implementation of the European patient summary, which can support patients moving from Ukraine to Moldova or Poland. Now, actually, if hand on heart, the future use of this, I think, is going to be quite limited, but there are initiatives going on to do this, so it's worth doing as an initiative. Quite how useful it's ever going to be to refugees, I don't know, but from an eHealth point of view, it's a useful thing to do, and it has some long-term knock-on benefits as well in doing it. The main issue is that to get a European patient summary in digital form, there are some issues about the national gateways, which in the architecture is called national contact points, and the issues there are both legislative, because obviously legislation is different in the different European countries, even though all part of the EU, and Ukraine and Moldova aren't in the EU. So you have to have alignment for just the permission to exchange information. You have to have some national eHealth infrastructure, which neither country has to the degree which is needed for exchange at the top level. But actually the biggest problem is down the bottom there, is assembling the electronic information to go in the patient summary itself, because a lot of that information is not available in electronic form. It's on paper, or it's partially available in electronic health record systems, which are not properly integrated. So there's an issue about integration and scanning paper records as well, and bringing them into the health record repository, so that can contribute to the European patient summary. So that sort of brings us to the end, except to say that that initiative in Ukraine is part of a wider initiative that I have going. It's just started, and in fact, the implementations in Ukraine were supposed to be in a few years' time. So we've sort of accelerated what's going on there. We were originally going to start in sub-Saharan Africa, actually in Uganda and Benin. But now, in fact, we've started in Ukraine and we're pulling in sites in Nigeria and Rawalpindi in Pakistan as low-income countries. The idea of this program is actually got various strands to it. One is a research program to generally research both attitudes towards open source software in healthcare, both in low-income and more developed countries. Secondly, to evaluate the implementations which are made, particularly in low-income countries, but also some implementations which are being made in the UK and in New York. And then third, so that's the research program, an education program, because one of the issues that we can already see in Ukraine, which you can see as a knock-on of the World Bank funding, is that if you install with capital funding, you need to look at how you're going to make a sustainable health system and e-health infrastructure going forward. And part of that is educating people on the ground in those countries to be able to sustain it for the future. So have an education program, which we initially be going with the technical college and the university in Rivne as an experiment to start with, but actually we already have people who are educating through master's programs from Rawalpindi, from Nigeria as well, already being educated past the education program. And then finally an implementation program, so implementing open source software, driven by the local NGOs, the non-government organizations, supported by national government, and with the idea of open source software implemented and supported by local technicians and clinicians who've been trained through the education program. So if you look in the top right-hand side, you'll see a rather cheeky UVic logo under University of Oxford. so your UVic's already roped into this program. It might be news to Andre, but coordinated by Abdul Rizadi, who's, I think, on this call as well. Right, so that's, I think, brings us to the end of our presentation. I've, as I said, tried as much as I can to steer clear of politics, but I welcome any questions on either the e-health or the politics are welcome.